So this is chapters 9 and 10. It's the lifespan. So when we start, we're going to start with our lifespan, which is infancy through middle adulthood, which is chapter 9. And we start with what are our growth and development. So growth would be the physical changes that occur over time, such as increases in our height, sexual maturation, our gains in weight and muscle tone. Growth is your physical aspect of development. The rest is behavioral. Then we have development, which refers to the process of adapting to one's body and environment over time, which is enabled by increasing complexity of function and skill progression. A few examples of development are a child who comes to recognize right from wrong, an adolescent who decides on a vocation, and an older adult who recognizes nearness of death. We have our principles of growth and development. So growth and development usually follow an orderly, predictable pattern. However, timing, rate, change, and response to change are unique for each individual. We have our two different, so our growth beginning at the head and progression down to the chest, trunk, and lower extremities. To illustrate this, when an infant is born, the head is the largest portion of the body. In the first year, the head, chest, and trunk gain in size, yet the legs remain short. Growth of legs is readily apparent in the second year. An example is the tendency of infants to use their arms before their legs. And then we have our development, which is proximal distal pattern, beginning at the center of the body and moving outward. An example of proximal distal development is the infant first begins to focus their eyes, then lifts the head, later pushes up and rolls over. As the infant gains strength and coordination distantly, they will crawl and then later walk. Other principles of development. We have simple skills developed separately and independently. Later, they are integrated into more complex skills. Many complex skills represent a combination of simple skills. Each body system grows at its own rate. In the years leading up to puberty, the cardiovascular, respiratory, and nervous systems grow and develop dramatically, yet the reproductive system stays the same. Puberty is a series of change that leads to the full development of the reproductive. So what that's saying is that that particular system changes very little until puberty hits, and then it's fully developed. Body system functions become increasingly differentiated over time. Have you ever heard a newborn respond to a loud noise? A newborn startle response involves their whole body. And with maturity, the response becomes more focused. For example, covering of the ears. An adult is often able to state the location of the sound and distinguish the origin of the sound that startled them. We have some developmental theorists. So the first developmental theorist that your book talks about is Robert, who theorized that learning is a lifelong process. He believed that a person moves through 6 stages of life. Each is associated with a number of tasks that must be learned. These developmental tasks midway between the individual need and societal demand. Failure to meet and master the task leads to an imbalance within the individual, unhappiness, and difficulty mastering future tasks and interacting with others. We have Freud. Freud was a psychoanalytical theory. And he believed that human development is maintained as an intrinsical drive, such as libido, which would be your sexual instinct, aggression, and survival. Different drives predominate depending on the age of the individual. In Freud's theory, personality consists of the id, the ego, and the superego. Different parts that develop at different life stages. Each factor or force has a unique function within our development. We have a cognitive development theory, and this is by Piaget, and he believed cognitive development requires 3 core competencies: your adaptation, your assimilation, and your accommodation. Cognitive development occurs from birth through adolescence in a sequence of 4 stages. We have sensory motor, perioperational thought, concrete operations, and formal operations. A child must complete each stage before moving to the next. The rate at which a child moves through the 4 stages is determined by their inherited intellectual and the influences of the environment around them. Another theorist is by Erik Erikson, and his theory us as individuals must negotiate through 8 stages as they progress through the lifespan. Most people successfully move from stage to stage. However, a person can regress during times of stress to earlier stages, or be forced to face tasks of later stages because of unforeseen life events such as terminal illness. Failure to successfully move from stage leads to maladjustments. Erikson's theory is widely used in nursing and in healthcare. We have moral development theories by Kohlberg, who developed his theory of moral development by studying the development of 84 boys over a 20-year period. In this theory, moral reasoning appears to be somewhat age-related, and moral development is based on one's ability to think at progressively higher levels. Increased maturity provides some degree of higher level thinking, but does not guarantee the ability to function at the highest cognitive or moral level. Then we move on to Gillian and Kohlberg. So Kohlberg had moral development. He developed his theory, and I just said that, I'm sorry. So after Kohlberg is Gillian. So Gillian described a 3-stage approach to moral development. His stage 1 was caring for oneself. The focus is on providing for oneself and surviving. The individual is egocentric in thought and does not consider the needs of other. When concerns about selfishness begin to emerge, the individual is singling and readiness to move on to stage 2. Stage 2 is when you can care for others. So perhaps a woman that recognizes the importance of a relationship with others. She's willing to make sacrifices to help others, often at the expense of her own needs. When she recognizes the conflict between caring for herself and caring for others, she's then ready to move on stage 3. Stage 3 of his theory is that caring for self and others. And this would be the highest stage of moral development. Care is the focus of decision making. The woman carefully balances her own needs against the needs of others to decide on the course of action. And then our last one would be the spiritual developmental theory by James Fowler. He was a minister. He defined faith as a universal human concern and a process of growing in trust. He noticed that his congregants had very different approaches to faith depending on their age. Based on his studies and the work of Piaget, Erikson, and Kohlberg, he developed a theory of faith based at which being a theory of faith development, which include a pre-stage and 6 stages of faith. So I just want to talk a little bit more about Erikson right now. So these are the different stages of Erikson, and you'll continue to see those throughout nursing school and probably even to your NCLEX. And I know that a lot of hospitals test annually on Erikson stages of development too. So each of these stages is a building block, and each is crucial during our across our lifespan. These stages do not end with one and begin with another. They kind of overlap. And as I said earlier, if you have a traumatic event, we can be pushed back into stages. So sometimes you hear that a school-age child might have a traumatic event and they'll start wetting the bed again. And that theory can be based on the trauma has made them regressed in their stages. So it's good for you to learn these and what each of these stages means. So we had the first question, which is which theorists identified the three core competencies of adaptation, assimilation, and accommodation? And the correct answer to that would be Piaget. So now we're going to move on into our stages of our actual development. And we have our 10 stages of development, starting with gestation. And we need to be able to know each of these periods and understand what health problems, assessments, and interventions would be appropriate for each. So when we start with our gestational period, we know that our gestational period starts at the time of conception and ends at the time of birth. The human gestation is calculated from the first day of the mother's last menstrual period and lasts for approximately 40 weeks. The first 8 weeks is known as the embryonic phase, and by the end of 8 weeks, all the organs are formed and the embryo is then called the fetus. Health problems that can occur during this gestational period is teratogen exposure. So teratogens are substances that interfere with the normal growth and development of the fetus. Examples include alcohol, nicotine, morphine, narcotics, and other substances like cocaine, crack, and methamphetamines. The mother's age can also influence the growing fetus. Maternal disease, such as rubella, syphilis, gonorrhea, and although not common, but gonorrhea can cause blindness, death, and fetal loss. The mother's health, weight management before conception contributes to fetal and maternal health. The recommended average weight gain for pregnancy is 25 to 35 pounds. The expected weight gain is higher for underweight women and lower for overweight women. This is the slide just giving you a better visual understanding of the teratogen effects. And during the development week of the fetus, what it could potentially cause. So when we're the nurse and we're caring for this pregnant mom, we need to do our routine assessments. So your routine prenatal visits and screening usually takes place monthly until they're 28 weeks, then every 2 weeks until they're 36 weeks, then weekly into birth. You want to get her vital signs on her weight, fetal heart tones, nutritional status, and other measures of maternal fetal well-being, such as what common discomfort she might have associated with it, if she's having nausea, fatigue, back pain, if she had any pre-existing conditions, what medication she's using, because we know certain over-the-counter medications can be a teratogen effect on the baby. We also want to do screenings, so screenings for birth defects. Women who are at a higher risk for fetus with birth defects are those with advanced maternal age, which would be over the age of 40. Family history of congenital abnormalities, maternal diabetes with insulin, viral infections during pregnancy, and exposure to high level of radiation. Blood markers, ultrasound screens are done to detect neural tube deficits, abdominal wall deficits, trisomy 21, which is Down syndrome, and trisomy 18. Gestational diabetes screenings are often done between 24 and 28 weeks. Earlier, if there's a history of it. And then Streptococcus B. The recommendation is that pregnant women be screened for group B Streptococcus between 35 and 37 weeks. We want to make sure that our moms are taking in enough calories. Their calories should increase by 10 to 15%. Their protein needs to be adequate because inadequate protein affects the formation of both the placenta and the fetal brain. And they need to have an increase in folic acid to about 400 mics daily to reduce the risk of neural tube defects. Vitamins and minerals also need to be included. Women need 25 to 50% higher than non-pregnant women. Again, the mother's nutritional status should be assessed, and we should provide teaching. And this assessment should be encouraged as soon as possible. So if you have a family who's planning to have a baby, that would be an important measure for you to do with your moms. Next, we have our neonate. So we know that our neonate is birth to 28 days. And if the baby is born early, they get 28 days plus the additional days that it would take to get them up to their birthday. So if I was supposed to be born July 30th and I was born July 25th, I would have to be the 28 days plus the 5 days that I came early. So it would be birth to 33 days. Okay. But for this period in your career school, that's not that important. We just need you to know that it's birth to 28 days. So the most critical adaptations is this baby establishment of respirations, right? They're being born. They had a lot of pressure on the baby's chest during the vaginal birth. We need to make sure that the elimination of amniotic fluid occurred and that the lungs are ready to be breathing. The normal newborn's respirations are irregular, shallow, and 30 to 50 breaths per minute. With brief periods of pausing. The cardiovascular system must also adapt to the change of placenta blood flow to an independent circulation. The average heart rate of the newborn is about 120 to 140. They do have slower rates at rest and higher rates when they're pregnant or active. Children can be born with poor peripheral circulation, causing a bluish discoloration of their hands and feet. This is normal and it usually disappears within a few hours. Thermal regulation is another critical task at birth. The newborn can produce adequate heat, but cannot protect themselves against heat loss. So we need to make sure that we wrap them up appropriately after we dry them off. At birth, the kidneys produce 15 to 16 mLs of urine per kilogram. During the first 24 hours, the newborn voids approximately 5 to 25 times. Newborns have limited ability to concentrate their urine. At birth, the newborn's lower intestine is filled with meconium. This is a sticky greenish black substance formed from the amniotic fluid in the intestinal secretions. Meconium is usually passed within 12 hours of birth, and the stool progressively changes to yellow. Our babies should all be born with reflexes at birth. These reflexes need to be tested by the nurse. We have rooting. Rooting is elected by stroking the infant's cheek with the nipple or the finger. In this response, the newborn will turn their head towards it and simultaneously open their mouth. They take hold and they suck. This reflex typically disappears within 3 to 4 months. This sucking reflex is elicited by touching the infant's lips. Swallowing is coordinated with sucking and usually occurs without gagging, coughing, or vomiting. The grasp reflex is triggered by placing a finger in the palm of the infant. By placing your finger in the palm of the infant or at the base of the toes. The infant's fingers or toes curl around. This reflex is usually lessened by 3 to 4 months. And the last reflex we'll talk about is the Babinski. So the Babinski is a reflex that's elicited by stroking upward or along the lateral aspect of the sole. A positive response occurs when the toes hyperextend to the great toe dorsiflexus. The infant who does not respond in this manner needs to undergo a neurological evaluation. The reflex of the Babinski disappears as the infant begins to walk. This will be around 12 to 18 months. We test for this and we provide the family with education that the child should be responding as anticipated. Our common healthcare problems with these babies is that they can have respiratory distress. especially if the meconium was passed during birth. They can have pale mottled skin, labored respirations, become hypothermic and flaccid due to that. They can have birthing injuries with fractured clavicles from birth, going down the vaginal canal. They can have congenital abnormalities. Some of these could be caught prior to birth or could be noticed after the fact. They can have jaundice, which can occur within 48 to 72 hours after birth, when the newborn's red blood cell count normally begins to decrease. One byproduct of the red blood cell destruction is bilirubin, and it will create a yellowish pigmentation. The child needs to be under phototherapy or sunlight to break that bilirubin down. So sometimes they'll stay in the hospital longer. They can have fetal alcohol syndrome if the infant is born to a woman who is drinking alcohol during a pregnancy. And then we have mothers with substance abuse that the neonates are born withdrawing. So they have neonatal abstinence syndrome. And these kiddos can have distress with their breathing, behavior abnormalities, and other birth defects, as well as the drug withdrawal effects. So the assessment on these guys, you're going to want to do an APGAR scar when they're first born. You're going to want to make sure that we're assessing our feeding concerns. We're going to be looking at our normal reflexes. And there's plenty more, but you'll learn about the rest of it another day. So moving on, we go to our infant. Our infant is 1 month to 1 year. So growth during the first year of life is very rapid. Infants gain about 1.5 pounds per month for the first 3 months. Birth weight typically doubles by 5 months and triples by a year. Length increases approximately 1 inch per month until 6 months of age, and then it slows to 1 inch over the next 6 months. Head circumference increases about 33% in the first years. Piaget describes the infancy phase as cognitive development as sensory and motor phase. Although this, we are still having the neonate responses in a reflexive manner, the infant makes major strides in motor development and is able to vocally interact with caregivers. An infant's visual acuity and color discrimination allows them to see and explore their environment. Hearing becomes more discriminating, and the infants please themselves by vocalizing with cooing, laughing, and repeating sounds. In infancy, the central task remains the development of trust. The response of the caregivers in the neonate phase has set the tone for ongoing interaction between caregivers and child. Continued prompt response to discomfort, cuddling, and stimulating interaction provide the infant with a sense of trust in the world. So we have the growth, which we just talked about. They begin to have their teeth. This varies among children, but there's a distinct predictable pattern for the eruption of them. The first tooth typically appears between 6 to 8 months. The first to appear are usually the lower incisors, followed by the upper incisors. Infants typically feed about 30 ounces of breast milk or formula per day. By 4 months of age, breastfeeding is recommended. I'm sorry, I've kind of read that too fast. So with the feeding, infants typically consume 30 ounces of breast milk or formula per day by age 4 months. Breastfeeding is recommended for them because it's considered the most complete nutritional source for infants up to 6 months of age. Some physicians say up to the first year. The book says 6 months. Sleep patterns vary among infants. Generally, by 3 to 4 months, the infant has developed a night pattern of sleeping and can sleep approximately 10 hours. Infants vary in the number and length of naps they take, but the total numbers of hours is about 15 per day. Motor development follows a predictable pattern as well. Piaget describes the infancy phase as cognitive development and sensory motor phase. In infancy, the central task remains the development of trust. So our common health problems with these kiddos, there's colic, and colic is when they're fussy and you think that they're having some GI upset. Colic typically disappears at about 3 months of age. We have failure to thrive. This is when an infant is deprived of comforting and responsive relationship with the mother or another caregiver. Failure to thrive, they'll not gain weight and they'll be unable to meet age-appropriate developmental tasks, being malnourished, and they have different interacting with others. Failure to thrive can also stem from an organic cause, such as a disease or a withdrawal from a drug. We can get dental caries, especially if the parents leave them with a bottle of milk to sleep and the milk pools in the back of their mouth, which the milk contains sugar, and that will cause the tooth rot. This age, we can also get abuse and neglect. The youngest children are the most vulnerable to maltreatment. The book gives the stat that in 2013, 52 states reported that more than 1/4 of victims were less than 3 years of age, and the rate was the highest for children that are under 1 year of age. Unintentional injury is something that can hurt these guys. So automobile accidents or a major cause of death in infants because they're not properly restrained. Falls, burns, chokings, drownings are also common incidences. And then we want to just touch on sudden infant death syndrome. This is a sudden death of previously healthy infant with no explained cause. Even postmortem examinations fail to reveal a cause of death. The peak incidence of this is usually around 3 to 4 months. However, it's been known to occur up to 12 months of age. An increased incidence is associated with babies that were premature, had low birth weight, males, African Americans, smoking in the household, swaddling, and putting the infant to sleep in the prone position. So the assessments on these kiddos, we need to have office visits at 2, 4, 6, and 12 months. Our interventions are going to focus around nutrition, colic, making sure that they get their appropriate immunizations, that they're playing, that they're safe. Dental stuff. So now we move on to our toddlers. Our toddlers are 1 to 3 years of age. Compared to infants, toddlers' growth rate is much slower. The average toddler gains about 5 pounds per year and increases in height by 3 inches. Length is added mainly in their legs. By the second birthday, the typical toddler weighs 27 pounds and is 34 inches tall. The head circumference is equal to the chest circumference. Between 12 and 18 months, their anterior fontanelles, so their anterior soft spots, are closed. During toddlerhood, the child completes Piaget's sensory motor phase and moves into the preconceptual phase. This is a time of rapid language development, increasing curiosity. The toddler is able to name many things and objects, such as balls, blocks, puzzles. And they may begin to name those toys out loud. The most important psychosocial developmental task for the toddler is initiative, more independence, control, and autonomy. Erikson refers to this stage as autonomy versus shame and doubt. To successfully negotiate this stage, the child must learn to see themselves as a separate from their mother. They tolerate separation from their parents, withstand delayed gratification, learn to control anal and urinary sphincters, and begin to verbally communicate and interact with others. Common health problems with your children, unintentional injury occurs. Drowning is the leading cause of accidental death. Most drowning accidents revolve around unsupervised access to swimming pools or other water sources like bathtubs. Other common causes of injuries to the toddler are falls, accidents, burns, and scalds and choking. As toddlers gain increasing mobility, poisoning from household medications and toxic cleaners can become a concern, as does knives, guns, and other dangerous items. Infections are the most common infection for these guys are colds, ear infections, and their tonsils. Other common infections includes parasitics diseases like lice and tapeworms. The shorter flatter eustachian tubes in infants places them at an increased risk for those ear infections, which can create hearing loss. Immunizations need to be continued. The CDC's immunization schedule for toddlers includes hepatitis A, B, influenza, meningococcal, TD, Tdap, MMR, and rotavirus. It can also have delayed toilet training. Many parents are concerned about what they perceive as delayed toilet training. Physiologically, most children develop sphincter and neurological control by age 2, but there's more involved in successfully toilet training. Children must be able to unfasten their clothes, pull down their pants, use toilet paper effectively, dress again, wash their hands before they can complete this task independently. The child must also be able to sense the need to go to the bathroom, even when preoccupied with play activities, before it's too late. Accidents are frequent and should be expected. So what we're going to assess on these guys if they come into our job and we're providing nursing care for them. Children of this age are generally feel for strangers. Before beginning our assessment, we will need to establish a rapport. To do so, we might engage the child in some play. We use a non-threatening way to assess the child and with toddler language skills and motor development. We want to encourage the parents to relieve the child's stress by holding them during the exam and speaking to them calmly and reassuring voice. Toddlers need regular physical activity. At each office visit, we need to assess the toddler's height, weight, growth, development against the standards in the chart. We want to compare their skills against age-appropriate norms. And beginning at age 3, blood pressure should be checked at least once a year, and the results recorded with the age, gender, height percentile, and reviewed with the parents. Interventions at this age, again, should focus on our health promotion and disease prevention and safety. So they still need to be in their car seat, they still need to have good dental care, they still need to have good nutrition, and all of that stuff. So next we move into our preschoolers. So the preschool age is 4 years they get to school. Right, so it would be till 6. So by 4 years of age, the average preschooler weighs 36 pounds and is 40 inches tall. By age 5, the preschooler has gained an additional 5 pounds and grown 3 more inches. The proportions of the head to trunk are somewhat closer. The pot belly or exaggerated lumbar curve of the toddler gradually disappears. The average heart rate is about 90 to 100 beats, and respirations in this age group are 22 to 25. The child now has the ability to communicate needs through language. Verbal skills are expanded dramatically during this phase, allowing the child to interact with more people. Preschool children are very interested in books, learning to read, and counting. They're now able to separate from their parents and they develop a consciousness. The preschooler is in Erickson's stage of initiative versus guilt. This is the stage in which the child develops a conscious and readily recognizes right from wrong. The child becomes socially aware of others and develops the ability to consider other people's viewpoints. At this age, play is often used to teach life experiences. Our common health problems with our preschoolers: communicable diseases, the transmission of viruses through direct contact and airborne, because they're now using play structures and in school with a lot of other children. Poisoning remains a significant risk factor for preschoolers, and we still need to make sure that things are locked up in home and kept safe. Parents of preschoolers may report a concern about bedwetting, especially in boys. The cause of nighttime bedwetting is not fully understood, but it's known that some children, the bladder is simply unable to hold a full night's urine until later in childhood, whereas others lack the neurological ability to awaken in response to a full bladder. Most cases resolve spontaneously with occasional episodes past 6 years. In contrast, daytime wetting or soiling requires evaluation. Child abuse can occur at any age and any culture and at any socioeconomic education level, but we need to be aware and look for child abuse. And if an adult is making negative comments about their child or comparing their child as a negative, that should be a alarm for us that something could be wrong. Then we have our assessment of our preschooler. We want to make sure that we're taking their height and their weight, we're calculating their body mass index and make sure that it's plotting accordingly. We're going to be looking at their nutrition, assessing for food preferences, habits. Preschool children often have strong food preferences. We want to know what their sleep habits are, assessing the amount of hours slept, their bedtime rituals, any problems with night wakenings. We want to do vision screening. The U.S. Preventative Service Task Force recommends vision screens for all children at least once between the ages of 3 to 5 to detect the presence of vision loss. We want to continue to do dental hygiene. Children should have made at least one visit to the dentist by the age of 3. We still have safety risks, such as hazards and precautions, because now the preschool child is very mobile and involved in active play, so their accidents increase. And we're going to start to look at school readiness. Physical examination is required before the child enters school. This exam should include an assessment for readiness, whether the child has the acquired skills, such as an ability to converse with adults, follow instructions, hold a pencil, and perform a variety of motor skills, such as jumping, hopping, and walking in a straight line. We also want to review their immunization records. Several boosters and immunizations are due at the time of school, and any that are missed, the child could be prohibited from entering the school unless they have an exception. So now we move on to our interventions. So things that we're going to do. We want to teach this child about frequent hand washing because we want to stop that spread of those communicable illnesses. We want to make sure that they're doing proper brushing and flossing because their parents will probably start having them do it on their own. We want to continue to encourage the essentials of the balanced diet, adequate rest. This preschooler requires about 12 hours of sleep a day. We want to start to talk about hazards of stranger danger, the importance of seatbelts in cars, and again, the safety with the child abuse comes back into play. So our question here is, how do your communication skills enhance the success of an interaction with a preschool child with the family? How would you improve your therapeutic communication skills? And you guys can think about that. I'm going to continue on. So we have our school age child who's 6 to 12 years old. So this school-age child undergoes many changes. The child becomes more independent, places more importance on the relationships outside their family, and becomes more confident. Growth for this age is about 2 inches, and they gain about 4 to 7 pounds per year. The child takes similar appearance with longer legs and lower center of gravity. School-age children use their thought process to experience action and events. Piaget describes this as concrete operations. The child's thinking is concrete and symmetrical. Magical beliefs are gradually replaced with a passion to understand how things really are. They also are able to see another person's point of view and develops an understanding of relationships. But these guys, they're at similar risk to those as preschoolers with their respiratory infections, parasitic infections, lice, and dental caries. Now we're going to start to see things like childhood obesity, type 2 diabetes coming out, hyperlipidemia, childhood high blood pressure, childhood asthma, can become diagnosed, which would be that chronic inflammatory disorder of airways. It's one of the most common chronic disorders in children. Unintentional injuries, these guys are way more active, so they're going to be riding their bicycles in the streets, skateboarding, sledding, playing sports, playing on playgrounds. So now we're going to be getting fractures, sprains, strains, cuts, and abrasions. And going back to the concern of child abuse, we need to make sure that the injury matches the story that we, the healthcare provider, are being told. So our assessments, school-age children should have routine health maintenance visits every 1 to 2 years. Annual physical exams are scheduled if they're playing in sports. Nutrition, children's eating patterns and intake need key nutrients such as calcium, vitamin D, and iron. Allergies, as the child, we need to ask the child whether they've ever experienced difficulty breathing or feels too tired to play. Ask about symptoms like clear nasal drainage, frequent sneezing, watery eyes. We want to listen to their breath sound and observe for symptoms of allergies. We want to do a visual acuity. And with this age, if they're able to read, we can have them do the letter chart, the letter spelling chart. If they're still not sure of their alphabet and having delays, we can do the picture chart. We need to continue to do dental hygiene. We need to interview the child to determine their knowledge of dental hygiene. We need to inspect the mouth for secondary teeth eruption and look for teeth decay and gum disease. Sleep patterns, these guys should have about 9 to 10 hours of sleep each night. We need to make sure that the child's aware of safety, that we're looking at their BMI. We're going to start to do scoliosis screenings in school. And remember, the scoliosis is the S in the back from the spine being curved. And again, we need to keep the immunization record and make sure that they're following up and they're getting their pneumococcal, influenza, hepatitis, A and B, polio, measles, mumps, rubella, varicella, tetanus, diphtheria, and pertussis. Our interventions for these guys, again, we're going to be looking at safety, we're going to be looking at nutrition, we're going to be looking at diabetes, violence, and risky taking behavior. Next, we have our adolescents. So our adolescents is 12 to 18 years old. These guys are transitioning from childhood to adulthood. Puberty refers to the beginning of the reproductive abilities. In this period of development, the child experiences progressive physical, cognitive, and psychological changes. The major task of the adolescent is to achieve a personal identity and avoid role confusion. The major psychosocial task of the adolescents is to develop a personal identity. Teenagers shift their emotional attachments away from their parents and create closer bond amongst their peers. This helps the teenager to further characterize the difference between himself and his parents. They also take on a new style of dress, dance, music, hairstyle, develop personal values, and begin to make choices about their career and future education. Common health problems with these guys is we can have substance abuse, which is a major concern. It can be due to physical, mental, spiritual toll, all of those things that affect our teens. Parents need to know that they need to provide education, even if they themselves are not using substances, because they have friends and their friends might be using it. So parents need to give the education no matter what. We need to be concerned about depression. This is a risk factor for adolescents. They can be depressed from cigarette smoking, stress, loss of loved ones, breakup of a romantic relationship, learning disorders, chronic illnesses, abuse, neglect, or other traumas or natural disasters. Suicide, we have risk factors for suicide due to school, romantic, family relationships, low self-esteem, social isolation, substance abuse, and depression. We can have eating disorders. Although anorexia and bulimia create nutritional problems and manifest as eating disorders, it's actually a psychiatric disorder that requires medical and psychiatric intervention. Overweight and obesity continue to be a concern during adolescence, partly because the incidence is so high. Moreover, overweight children are more likely to be overweight adults. And then we have our risky sexual behavior. So sexual activity is common amongst teenagers. We need to make sure that they're aware of how they get sexually transmitted disease, and that although a condom is not 100% effective, it would help reduce the chances of sexually transmitted disease or pregnancy. So they should be having protected sex. The assessment of adolescents, their general health examination should occur at least every 2 years, and we should obtain a health history and perform our general survey on these guys. Our interventions, our focus, age-specific interventions on educating the teenager about common health problems and avoidance of injury and disease. Topics we could go over would be preventing and treating obesity, prevention of pregnancy and sexually transmitted diseases, breast and testicular self-exam, self-awareness, continued with immunizations, getting adequate rest, getting proper nutrition, and maintaining their dental hygiene. So the stage of Erikson's psychosocial development that corresponds to the period of adolescence is identity versus role confusion. And remember, this is why if they have bad friends, they might lose their identity and become confused and do bad things. So, skip that, and we're going to move on to the young adult. So the young adult is 19 to 40 years old. This young adult is the time of transition to independence and responsibility. This transition involves important life events such as graduating high school, entering college, starting a career, leaving home. The 20s are spent exploring occupations, marriage, and alternative relationships. Young adult is usually the healthiest stage of a person. Your maturation of the body systems is complete. Peak bone density is achieved for both males and females by the age of 25. Vision and hearing are typically acute. For women, the ages of 20 and 30 years are optimal for childbearing. For men, hormonal levels surge in adolescence and begin to decrease and stabilize around age 24. Young adults begin to explore options for careers and intimate relationships. They strive to become less dependent and more self-sufficient. Around age 30, most young adults experience a period of self-evaluation. This often results in job, career, or relationship changes. Erickson describes this period as the stage of intimacy versus isolation. Successful completion of this phase requires establishment of lasting friendships and association. Freud describes this phase of life as the general stage. He believed that young adults are driven to form sexual, intimate relationships. So our common health problems with young adults are going to be sexually transmitted diseases, abuse and neglect, and obesity are things that we're going to want to check for. And with our assessments, we're going to do an annual physical exam, which would be a physical health, mental health, and lifestyle assessment. We need to assess their nutrition, exercise, sleep, use of tobacco, alcohol, street drugs. For women, they should have their pelvic exams. Nursing interventions for the young adult are similar to those for the adolescent and include breast cancer screening and exercise. Moving on, we have our middle adult. So your middle adult is 40 to 64 years old. One principal change that middle adult women experience is menopause. Once the menstrual cycle is gone for at least 12 months, we consider that menopause. The ovaries are no longer producing eggs on a cycle basis, and reproduction ability is lost. Although some women do become pregnant after not having their menses for a year, the average menopause age is 51. Women should be advised to consult their physician about issues and about bioidentical therapies and natural remedies that can provide symptom relief for their menopause. Andropause is characterized by a decrease in testosterone production, a low sperm count, and a need for more time to achieve an erection. Andropause does not result in the inability to reproduce, but does limit reproductive abilities. The middle adult years are a time when people realize the difference between their early aspirations and their actual achievements. For families with children, this is often a time when children mature and leave the home. As a result, many middle adults and their children feel a need to redefine family roles. Common health problems with your middle adult are going to be cancer, obesity, diabetes, high blood pressure, and other cardiovascular diseases. Your assessments, these guys are going to get their annual physical exam. In addition to the height, weight, BMI, and vital signs, the exam should also include a lipid panel, blood sugar screening, clinical breast and pelvic examinations, annual or biannual mammography for women. Digital rectal exam for prostate evaluation in men should be offered but not routinely done. Annual eye exam, colorectal screening, and osteoporosis screening. Practicing positive health habits may prevent the development of chronic illnesses later in life. Which positive health habits will the nurse teach to a middle-aged adult patient? Select all that apply. So routine health screening diagnostic tests, correct. Unprotected sexual activity, nope. Regular exercise, yes. Excessive alcohol consumption, nope. So critical thinking, you can do that on your own. And now we're going to move into the lifespan of the older adult. So this is chapter 10. So your older adult is the fastest growing age group, right? So from birth to age 65, women are expected to live longer than men. And then after 65, everybody is expected to live the same. We have the population pyramid, and the population pyramid is the age distribution of the population, and the oldest, which is the base, and the youngest, which is the peak. And right now, age 85 plus is at the peak. Men on the left of the figure and women on the right of the shape of the population pyramid changes to a rectangle in development in countries with fewer birth and increased life expectancies. To see the population pyramid, you can refer to your textbook. The major challenge when caring for older adults is their chronic health problems that cause loss of their independence. So we have our life expectancy, and we know that life expectancy is one way to view aging around the world. People in developed countries are living longer and longer and having fewer children. Life expectancy can be calculated and measured. And then we have our migration and distribution of age groups. In addition to life expectancy, and migration within countries and between countries contribute to distribution of age groups and the median age population. We have a percentage of total population, which is another way to view aging. And we have our lifespan perspective, which is another way to view aging. In this perspective, genes inherited at conception, behaviors expressed throughout a lifetime, and environments within which person lives, works, and plays interact with each other over time. The cumulative effect of these interactions is seen in older adults. So we have housing for the older patient. So aging in place is when as they age, the person lives in their own residence and receives supportive services for changing needs rather than moving to another location. We have age-friendly residences, which accommodations have been made to the physical structures, such as widened doorways to allow for assisted devices like walkers and wheelchairs. We have age-friendly communities, which are livable communities, also referred to as elder-friendly. And they emphasize older people's continuing participation in social, economical, cultural, spiritual, and civic affairs. We have naturally occurring retirement communities, and this is when people age in place, but because everybody bought at the same time, everybody in the location is getting old at the same time. So what ends up happening is this NORC, naturally occurring retirement community, and they typically will continue to develop accesses to service and maintain high quality for those people living in. Then we have retirement communities, and those are specifically built to house the older population. Purchase of a home in these retirement communities usually include services such as home maintenance and repair, landscaping, snow leaf, trash removal, and things like that. Typically, there's an annual association fee attached to it. Then we have continuing care retirement communities, CRCs, or life care communities. These communities offer a wide range of living and accommodations, from residential living, assisted living, skilled nursing care, rehabs, dementia care. We have our assisted living facilities. These provide supervision and assistance. Not all assisted living facilities allow for fully needed care. And then we have nursing homes. These facilities provide skilled and unskilled nursing. And no matter where your person lives, we need to ensure that they're safe. And if they're not safe and we're concerned, we need to make sure that we make their safety and priority number one priority. And we need to make sure that we report emotional and physical outcomes. So our theories of aging. We have theories on everything. The theory of aging, we have wear and tear, which proposes that when we have repeated insults and accumulation of metabolic waste eventually cause our cells to wear out and cease to function. We have genetic theories of aging, which propose that cells have a pre-programmed finite number of times that they'll be able to divide and work. And then after that, the genetic message within the various cells will no longer allow it to reproduce. Then we have cellular malfunction. And this hypothesizes that a malfunction in the cell causes changes to the DNA, leading to problems with cell reproduction. And then we have autoimmune reaction. And this is when the cell changes with age over time, and the change results in an immune system perceiving some cells as foreign substances and triggers an immune response to destroy the cells. Not everybody falls into an autoimmune reaction. Most people will have some type of wear and tear or cellular malfunction. So older adult is broken up into additional stages. We have our young adults, which is going to be 65 to 74. And that's your older adult, young old. So this young old is physical and psychological adaptations to retirement are paramount in this age group. Young old persons face barriers in health, such as lack of supplemental insurance for health screenings, or if physicals are not covered under Medicare. Self-perception of aging, changes in physical activity, and being stable, not participating in exercise before retirement. They have deconditioned states. Your middle older adult is ages 75 to 84. And the development change of the middle old person is an increasing isolation, solitary. They can be sedentary lifestyles. Although they can be physically active, they'll decline in the middle old group. Overall, there's some evidence that older adults represent the fastest growing segment of participants in competitive sports, with a rise in 80 plus or minus few years, finishers of road races such as the New York Marathon. And then your oldest adult, your oldest older adult is 85 plus. And the developmental changes of the oldest old are sensory impairments, oral health, inadequate nutrition intake, and functional limitations. For hearing, nearly half of the older men and 40% of the older women report difficulty hearing. This was higher for 85 plus age group. Vision of the 85 plus age group, 27% reported trouble seeing. Nutrition, they might need a diet of soft foods. They may need higher in fats, carbohydrates, and calories. But oldest adult, this occurs at the time when they need to decrease intake of these foods to combat obesity. We also need to realize that reaction time slows in the older adult and short-term memory declines. So taking longer to respond to stimuli and more time to process incoming information needs to be planned into their care. And we know that short-term memory might decline, but intelligence does not. Again, the older adult is the fastest growing. They can be frail. frailty has been distinguished in the following ways: a syndrome or a set of characteristics that describes a heightened state of vulnerability from developing adverse health outcomes, a multi-system reduction in a person's physiological capacity, and the point at which the human is believed to have its least capacity for survival and will fail in response to minor internal or external insult. For example, a frail older adult might die merely as a result of falling ill to an upper respiratory infection such as a cold. So which theory of aging focuses on the accumulation of metabolic waste? Is it the wear and tear, genetic cellular malfunction, or autoimmune reaction? And the correct answer is wear and tear. So we have our age-related physical changes. So with our musculoskeletal, we have a decreased muscle strength, decreased body mass, bone mass, joint mobility, and we have an increased fat deposit. Cardiovascular, we have a decreased cardiac output, an increased peripheral resistance, and an increase in our systolic blood pressure. Respiratory has a decreased elasticity of the chest wall, intercostal muscle strength. Cough reflex, increase anteroposterior diameter of chest, and rigidity of lung tissue. Gastrointestinal, decreased saliva production, GI motility, and gastric acid production. Your integumentary has a decreased skin elasticity, nail growth, increased dryness of skin, thinning of skin layers, nail thickening, and hair thinning. Your GU system has a decreased glomerular filtration rate, blood flow to the kidneys, bladder capacity, vaginal lubrication, and hardness of erection. Neurological, you have decreased nerve cells, neurotransmitters, REM sleep, blood flow to the central nervous system. Endocrine, you have decrease in insulin resistance, thyroid function, estrogen, and testosterone production. Sensory, decreased visual acuity and depth perception, tear production, pupil size, accommodation, acuity of smell and taste, hearing high frequency sounds, sense of balance changes and pain sensation, increased glare sensitivity, thickening of lenses of eyes, and changes in pain sensation. For older adults with dementia that are having cognitive issues, we can use reminiscing, which would be involving and exchanging of memories to help them feel that they have a sense of value and importance and a sense of belonging. We have a decrease in our short-term memory and an increase in our reaction time. And personality, we have increase in our cautiousness, retirement, widowhood, and grandparenthood occur. So our psychosocial development of the older adult, we have a disengagement theory, and this hypothesizes that the older adult and society gradually and mutually withdraw or disengage from one another. Mandatory retirement, chronic illnesses, death of relatives and friends, and poverty are among the factors that may contribute to the phenomenon. As interaction between the person and their world decrease, there's time for more reflection and more freedom from societal roles. Power transfers to younger members of society as the older adult withdraws. Disengagement is not the norm for the current generation of older adults in the United States, nor is it universally true for cultures that value elder people. Advice is essential for family decision making. Then we have our activity theory. So this is that the individual should stay as active and engaged as possible to enjoy the highest life satisfaction. On retirement, other activities such as travel, sports, hobbies, or volunteering replaces time spent at work. And then we have Havelock's theory, which is a counterpart of the disengagement theory. According to this theory, the following are physical, cognitive, and social development tasks of the older adult. So they are adjusting to decreasing physical strength and health, adjusting to retirement, to lower income, to the death of spouse. They're establishing an open affiliation with one's age group, adopting and adapting flexible social roles, and establishing satisfactory physical living arrangements. The psychosocial development, which is Erikson's developmental theory, is ego, integrity versus despair. As the task of the older adult, this stage of development has its cornerstone, the acceptance that one's life has had meaning and that death is a part of the continuum of life. This outlook allows a person to accept the inevitable changes in health and life circumstances. The basic virtue gained at this stage is wisdom. The older adult must face multiple losses, such as death of spouse. When you're 85 plus, it can be death of children, challenges of health, youthful vitality loss, loss of independence, loss of their negative psychological effect. So the leading causes of death is the heart disease, cancer, chronic lower respiratory, stroke, Alzheimer's, diabetes, accidents, and influenza. We can also talk a little bit more about Alzheimer's disease. Is the primary form of dementia and is considered progressive. Increasing age is the greatest known risk factor for Alzheimer's disease. Most persons with this disease are older adults. The odds of developing Alzheimer's disease doubles about every 5 years after the age of 65. About half adults age 85 and older have Alzheimer's disease. So other health problems of the aging adults. We have polypharmacy. And when we talked about class about polypharmacy, I used the example of my husband's grandmother who went to multiple doctors complaining about the fluid on her legs, and all these doctors were giving her different medications, different diuretics, and then she went to another doctor and complained about her inability to not pee all the time. So then he put her on a stop urinating drug, and then she ended up being in the hospital, and the ER nurse is the one that caught the fact that she was on multiple diuretics and plus a no-go pill. So polypharmacy is just the use of multiple medications, and it is a grave risk factor for confusion, delirium, depression, and even death in older adults. Depression for our elderly population can be evident, and we can usually link it back to like chronic medical conditions, chronic pains that they're having, disabling. So all of that, loss of loved ones. And then there's also ageism. So ageism is age-based discrimination. It's negative expectations for older adults can cloud nursing assessments or planning and our interventions. So we just need to be aware of that. So which is the normal developmental change of aging? Would be confusion and dementia, dry skin, joint pain, or loss of intelligence? And the answer is dry skin, right? Because normal development change would not be confusion, would not be joint pain, and it wouldn't be loss of intelligence. So a little bit more about our cognitive development. Again, normally memory might decline, but intelligence would not. Dementia is common in that 85 plus. It is not a normal part of aging, and typically Alzheimer's is the primary form. Dementia is irreversible. It has a progressive decline in mental faculties. They can have aphasia, with it, which is the loss of ability to communicate. They can have apraxia, which is the loss of ability to carry out purposeful movements. And they can have a nausea, which is impaired ability to recognize and identify objects. It can lead to the inability of them to be able to recognize family members even. So that can be difficult for family members, and we have to offer support that unfortunately is part of this disease process. They can also have disturbances in executive functioning, so their ability to organize, manage, and make decisions is off. Dementia makes it more and more difficult for the older adult to remember where things are, to think clearly, to communicate with others, and to take care of themselves. In addition, dementia can cause mood swings and even change a person's personality and behavior. So the assessment of the older adult, it's recommended to older adults they have an annual physical and dental exam. The exam should include same categories as the middle adult, as well as screenings for mood, cognition, and ability to perform activities of daily living. The instrumental activities of daily living, assessing for depression should be part of the assessment of them as well. Assessments specific for the young, old, middle old, and oldest olds. When assessing our young old, we need to know what their daily routines are, social interactions, short and long-term goals. This will help determine the degree in which the person has to adapt to their retirement. We have the level of fitness and the level of effort for physical activity. This and the following point are essential to determine before beginning a program of routine exercise. Chronic conditions, how a chronic condition affects the client's ability to do regular physical activities safely and to what extent. Barriers to exercise and client's self-confidence and ability to maintain and exercise problems. It is critical that you assess the function and support systems, social networks, and health. And this is in regards to actually the middle adults. The middle adult would be all of the young adult plus the function and support systems and social networks and mental health. And then the oldest adults need similar assessments as the middle old, but we need to keep in mind that the assessment of the physical, psychosocial, and cognitive abilities, as well as social engagement and living conditions, are crucial for the older adults. Psychosocial and environmental factors may be cues of virility when subtle psychological changes are not obvious. So if we've done our assessment, so now we go into our diagnosis for our older adults and things that we might have for our nursing diagnosis and our conceptual care plans. Could be a frail elder adult syndrome, risk for frail elder adult syndrome, nutritional deficits, which would be less than the body requires, and risk for impairment with our growth and development. Outcomes and evaluations. We want to maintain the person's ability to function independently for as long as possible. We want to arrange for appropriate care and teach clients and caregivers how and when to call for professional help. And if we're going to teach them how and when to call, they should be able to tell us how and when to call. Our interventions for our young old, we're going to want to encourage them to have regular aerobic physical activities, muscle strengthening activities, balance promoting, and we want to adapt physical activities that they can do. Some activity is better than none, right? A body in motion stays in motion. Then we have our interventions of our middle adults. So your middle older adult could have health crises that lead to decreased function and ability. We want to use encouragement. We want to make sure that they have support, and we want to do these planned program activities. And then we have our interventions for our oldest older adults. And the goal of the oldest old is to ensure independence for as long as possible by maximizing function and preventing disability or loss of function. So supportive environments and conditions that allow for a person to function. We want to modify and adapt activities, especially important for this age group, like walking, flexibility, exercise, yoga, tai chi, water aerobics, and nutrition, right? We want whole grains, dark greens, oranges, vegetables, beans, fruits, and all of that good stuff. Interventions for this group, we want to promote independence, maintain function, promote cognitive function, illness prevention, communicating with them and with people and their caregiver supports. And that is it for this lecture. So I hope that worked.